This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. I'm here with Harry Sutherland from Yale University. Harry is the lead author of a paper titled The Landscape of Adult Neurology Residency Didactic Curricula in the United States. And that paper was published in Neurology Education in March of 2025. In this paper, Harry and his collaborators conducted a cross-sectional survey of residency program directors in the United States to explore the current practices and the structures of didactic education within their residency programs. We know that the ACGME does require that programs implement and build didactic education to complement the clinical learning that happens in residency. But there's a high amount of autonomy between programs and on how these curricula are structured. There's no formula that everybody is following. And so Harry and his team sought out to explore the variety of the designs and sort of how different programs go about this. So Harry, no further ado, welcome to the podcast.
Hi, Jeff. Thank you so much for inviting me to the program. I'm a huge fan of the podcast and also of your work, so congratulations on your own recently published survey of residency program directors. I think it's very fun and interesting that they came out at similar times.
I appreciate it, and we're excited to have you, and let's talk high-level overview. So in this survey and in your analysis of that data, what would you say are the key take-home points when it comes to the lay of the land that's out there in residency didactic teaching?
Didactics were the core focus. We also looked a little bit at morning reports, at professors' rounds, and also at some asynchronous learning materials, whether external to an institution or internal to an institution. But in terms of focusing on that didactics, there are so many different ways that programs can fill the ACGME required 5 hours of programming per week. We saw that noon conference does predominate across programs. About 2/3 or 63% of programs are using a noon conference or daily conference model. That does tend to be weighted from our analysis towards the Northeast, whereas hybrid programs or those in the Southeast tended to have way more of a different type of design called the academic half day. In terms of what each of those conferences looks like, there are several different ways of protecting resident time to attend didactics and varying degrees of protection of that resident time, as well as offering food at conferences. But most conferences do offer a teleconference option. And then for the actual instructional methodologies for each of these conferences, most are lectures. Most are given by various faculty members, but there are, again, a couple of different styles of practice that we found scattered throughout different institutions. Overall, resident attendance tends to be about 2/3, but there are pretty wide margins on that 2/3 with a range all the way down to 10 up to 90%. And we did look at some factors that specifically drive attendance. So the three that we identified among other factors that didn't seem as significant, the three that do significantly drive attendance are: number one, residents not holding the pager; number two, having fewer hours of didactics per week scheduled; and number three, having more program director-led sessions. These all seem to be important in terms of increasing the amount of resident attendance at didactic conferences.
It's interesting that you don't have, and I think we all probably would have predicted, if you feed the residents, they're more likely to come to conference. But it sounds like that was not necessarily a determinant on attendance if food was provided for residents at conference.
We did find another article in the literature that did find that providing more regular meals did increase attendance. So it could be that maybe it perhaps doesn't, or it could be that our study just didn't find that because we didn't directly measure resident attendance. We looked at program director report of resident attendance. So that's a limitation of the study.
Fair. So let's talk a little bit about some definitions and what we're talking about. So when we talk about didactic teaching, people may traditionally envision sort of a faculty member sitting in the room, giving a lecture on a topic within neurology, working off a PowerPoint or a digital slide deck. But I think it's important for us to get into the fact that that's not the entirety of what didactic teaching is and not the only available option. And you did talk a little bit about asynchronous models and some of these other teaching methods that are out there. And so the question I have for you is, what are those different means that programs are using to teach residents outside of the clinical working environment? And what did you all learn about the prevalence or the amount of use of those different teaching methods?
So the ACGME provides some different options for programs to fulfill their programming are lectures, conferences, you can do case-based series, you can even do simulations, you can do labs. In terms of sitting down together and having a formal didactic, a lot of those from our analysis do tend to be lecture-based, so often a faculty member, but sometimes it could be a resident or a fellow sitting down either with slides or whatever other prepared materials they have. There are some places that are doing some case-based teaching, some more chalk talks, team-based learning, but lectures do seem to predominate. So we found that more than half the time at most programs, most of the didactics are in a lecture type of format, and most of those lectures are given by various faculty members rather than a specific faculty member or other trainees.
Some of the information coming out of this study is a little bit of the logistics. And you already talked about how do we get residents physically in the room or logged into the virtual room, whatever the environment may be. And we know that through the day, the needs of the patients on our various neurology services don't take a break so that the residents can go learn. And that can be a particular challenge to ask residents to walk away from their patient responsibilities, from the roles they're filling as clinicians in an era where complexity of patient care just seems to be going higher and higher. And so what are some of the system-based approaches that help allow residents to take time during the day to function as adult learners in the context of their training program? And also, when you're giving the residents that opportunity to be a learner, how are programs or departments maintaining the continuity of clinical care in the background?
You've put your finger right on the pulse. That really is the trade-off between getting people to be present at conference in a protected manner versus having more transfers of care and handoffs. From the responses that we got, about 80% of programs say that they protect the residents to some degree. At about 25% of programs, they said that the residents were completely protected. Most of the time when residents are at least partially protected, they're transferring pager responsibilities from a junior resident to a senior resident for probably about half or so of those programs, followed by some programs shifting that responsibility to either attendings or advanced practice providers at approximately similar rates between those two. And then in terms of getting people there, there's also the dimension of residents leaving rounds to go get food and then go to conference. So about half of programs provide food about half of the time. It didn't seem to drive attendance in our study, as you mentioned, but in other studies it has. And this is all about that balance of you want to try to reduce cognitive load. There's the extraneous load of you're a resident sitting at the table getting a lecture on myositis while you're also getting pages from the nurse or you're receiving consults on your phone, which pulls you out of the conference in terms of your mental headspace. But then the challenges are if you're not covering that patient or you're not providing that responsibility, who is? And does that lead to greater handoffs? Do those greater handoffs lead to, one, lapses in patient care in terms of safety? And does it also impair your ability to have that like immersive clinical experience that you need for your own learning?
I think your comment on cognitive load, I think, is valuable. As you were talking, I was reminded of a paper that actually the podcast founder, Ted Burns, wrote when he was talking about his experience with his cancer diagnosis. And he talked about this phenomenon of monotasking was the term he used, where it's important that our focus be on the task at hand. And so to draw that analogy to you, to have our residents have the opportunity to focus on the lecture or the educational activity, whatever it may be that they're engaged in, and to not feel that their attention is being divided elsewhere to, as you said, consults or other requests or communication from the rest of the care team. And to level up some of that protected time, and you've alluded to this phenomenon of the academic half day. And it sounds like even this phenomenon of the academic half day may be less common in Northeast-based programs and becoming more prevalent in programs in the Southeastern part of the United States. But as opposed to these periodic morning or midday teaching sessions, what is an academic half day? What does that comprise? And why would programs go to that model instead of maybe this more traditional noon conference or morning conference type framework?
I heard about an academic half-day model from a colleague I met at the AAM conference who describes doing it at their residency program, and I had never heard of it perhaps unsurprising because I had only interviewed at a limited number of large Northeast academic programs, which from the survey tend to be the ones that don't use it. But the basic premise is that an academic half day is a block of time, a couple hours, not necessarily a full half day. And in fact, we did find that programs that use an academic half day tend to have about 2 fewer hours of didactics per week overall, but that it's a block of time where you can spend a little bit more time and dive into a case or a discussion or whatnot. And I think that some of the benefit to academic half days and why some programs may gravitate towards them is, again, trying to reduce that extraneous cognitive load. But the one possible barrier to the academic half day model was, at least in the anecdotal experience of my former program director, that maybe you're sitting in your conference room for a couple of hours and you're becoming anxious as the to-dos are piling up and you're wondering how much you're going to have to do when you return back to the wards. In terms of other literature on the benefit of academic half-day, there are some programs from internal medicine and from pediatrics that have shown improved attendance, enhanced protected time, increased resident wellness, improved satisfaction. And there's even one study that showed improved in-service training exam scores when transitioning from a noon conference model to an academic half-day model. In our study, it did not drive attendance. We didn't look specifically at how much protected time was given with this different model. We did see that the programs that tend to incorporate this are those that are more hybrid, maybe outside of the Northeast. So maybe some of these programs are a little bit newer. So it's unclear if they had the academic half-day model from the outset or if they later transitioned to it and they had greater flexibility to be able to do that. But it's also worth noting that the study didn't comment on which model is better. There's nothing powered here to look at educational outcomes or patient outcomes. So it's just different models, not a comment on which one is better.
I think that last point's valuable, that the goal of you and your colleagues was to just see what's out there. And there's probably opportunities to follow up and see if we can try to figure out efficacy or the value of different types of teaching models. And another thing I wanted to hear more from you about was this morning report structure. And I think morning report and how people think of it may vary. I tend to think of a joint conference with residents and attendants where the topic of discussion is recent cases or perhaps even very fresh cases that, were admitted the night prior or within the past 24 hours. We're presenting patients that are actively under the team's care at that time. Is that description still apt? And how often is morning report being used? And is there any comment on how it's structured or what it looks like today?
There are a lot of ways of doing it. I think that is perhaps the way that a lot of people conceive of it. I'm actually not sure the historical origin of morning report, if that's necessarily how it started or if that's what it's become for many people. But even though that model is appropriate and is certainly present at many places, for morning report, even more so than didactics, there seems to be even more ways of doing it. So programs tend to have about 2 per week, so it's not necessarily every morning. And they go for about 45-ish minutes, some 30, some 60. In many of these programs, it's the overnight resident presenting a case. Perhaps it's a case that they saw overnight. But in terms of the presenter, it could be another resident. Sometimes even attendings or medical students might do it. And the person they're presenting to is oftentimes either a program director or associate program director, but can sometimes be various faculty members or even a more senior resident. And as far as that fresh case that you saw overnight and you wanted to discuss, only about 52% of cases from our study are almost always from within the past week. So it could be that people are hanging on to interesting teaching cases they saw from overnight, or at least the best teaching case they saw from overnight if they didn't find anything quote unquote interesting. But maybe some residents are looking a little bit further back to get something that they thought was even more interesting or rare or something that they thought they might want to discuss even more.
You're right. There's a lot of different ways to do it, but I think getting down to the root of it, having these case discussion, case-based learning opportunities, having resident practice, presenting the patient, communicating their thought process, getting dialogue and feedback on how they thought about it. And as you said, the structure can vary, whether it's the resident who is on overnight. My residents look at me wide-eyed when I tell them that, at the end of my night float shift or even at the end of my 24-hour shift, I'd have to stand up in front of the team and present patients from overnight. So I do think there's some ways that is still happening. And I think, as you said, sometimes the handoffs of care from nocturnal shift to daytime shifts is starting to become more prevalent. So as we finish up, let's turn our focus to looking ahead. So this article, as I already mentioned, was published in Neurology Education, which has really, since its launch, been providing a space for educators in neurology and clinical neuroscience to publish the latest in educational methods and landscape papers like this. And they've talked about simulation. They've talked about using social media to educate neurologists, talked about podcasts to educate, talked about all these digital tools. Given the knowledge you learned about what's out there currently, and also your just knowledge of the literature about what's out there in terms of leveraging technology to teach residents, let's look a decade ahead. What do you think the future of resident didactic education may look like? What should educators be on the lookout for? Or maybe what do you think they're already starting to implement that is going to be more common if you did this survey again 10 years from now?
There are probably multiple different futures. I think that different programs will probably chart their own paths to some extent. And there are definitely some programs that are experimenting even more with asynchronous models, whether models that they develop, resources that they develop, or resources that they're bringing from outside and recommending their residents use. Podcasts are a big one. I know that you actually had one on using podcasts to educate about neurologic emergencies, but the proliferation of innovations in medical education and the resources is tremendous. There's a good scoping review by Nick Morris about all the innovations that came out, I think, 2023 or 2024. But I think the essence of why do we do conferences is really at the heart of this question. So residents learn from their work-based learning, taking care of patients on the wards under the supervision of attendings. They learn from the formal didactic curriculum, whatever form that's going to take, and they learn from their own self-directed learning. And so what is the purpose of the didactics? Certainly, transmission of knowledge is part of it. But there's probably some of it that's also about fostering a community so that you have that community of peers for your experiential learning, whether in the didactic or even outside of the didactic session. And facilitating reflective practice maybe is part of didactics by having people reflect on the recent cases they have seen and things that they might want to incorporate next time. So I think that we're going to have to say, what is the most important element of didactics if it's not just the slide deck that we all think of when we think of formal didactics? It wouldn't be 2025 without somebody speculating about AI, but one thing that I wonder about is, will AI be able to help residents with clinical reasoning by presenting cases that residents can collaboratively work through together to work through the workup and management of a patient, and then taking breaks in that workup and management of the patient to provide more lecture-based type of material between each of those different steps of the case. So something like a clinical reasoning case, even from the resident fellow section, but just done with AI, with residents working collaboratively together and then learning from the course of taking care of that virtual patient.
The emphasis on having residents learn together is a valuable comment that you made there, and that the hearing the thought process of your peers, of the faculty, is something that is more challenging to replicate if you're going to have folks doing a virtual simulation or listening to a podcast or whatever asynchronous models that we educate with. Yes, knowledge can be transferred, but can we solidify our concepts and our understanding and our clinical reasoning processes? And hearing others go through that in real time can absolutely be valuable. Please do log on to Neurology Education, read Harry's paper, and just kind of get a sense of what's out there and how program directors are structuring these didactics. But Harry, thank you. I've been speaking with Harry Sutherland from Yale University about his paper that he and his colleagues published in Neurology Education. And again, the title of that paper is The Landscape of Adult Neurology Residency Didactic Curricula in the United States, a Cross-Sectional Survey. Harry, thanks again for joining us.
Thanks, Jeff. It's been a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.